Welcome to the Dr. Francavilla Show. I'm your host, Dr. Carolyn Francavilla, board-certified family physician and diplomate with the American Board of Obesity Medicine. I've been helping patients lose weight to treat and prevent medical problems for the last 10 years, and I'm taking what I've learned from them to you. In this podcast, you will learn the science behind why you struggle with your weight and what to do about it, tips for common challenges, work to fight bias about what a healthy weight really is, and improve your relationship with food and your body. Please remember that while I'm a doctor, I'm not your doctor. This podcast is meant to be informational in nature only, not medical advice. Please seek out care from your physician for your specific needs. Okay, let's get started. Hello, and welcome to this week's episode of the Dr. Francavilla Show. Today, I have a wonderful guest with us, Dr. Isabelle Amigues, a physician and rheumatologist, and she is joining us today to talk about rheumatologic conditions, joint pain, and the relationship between health, weight, and joint pain. So we're going to talk about that today. Dr. Amigues trained in both Paris as well as Columbia University in New York City and is currently based in Denver, Colorado, where I'm at as well. After being on faculty at National Jewish Hospital for over 5 years, she opened a direct care and concierge rheumatology practice here in Denver called Unabridged MD. She also has a podcast by the same name, Unabridged MD. We'll make sure that's in the show notes for you. She's a researcher and author of multiple book chapters and scientific articles, as well as a podcaster and speaker. At 40, she faced her own pivotal health moment when she was diagnosed with stage 4 metastatic breast cancer, leading her to explore alternative medical practices, the transformative effect of a whole food plant-based diet, meditation, visualization, energy healing, and the therapeutic power of love. Wow. And this not only affected her healing journey, but also enriched her medical practice. So I am so excited to hear what you have to share with us today about health and weight. Thank you so much for joining me today.
Well, and thank you so much for having me. It's such a pleasure. I always love to talk about rheumatologic issues and inflammation and weight and, all of those. So that's great. Yeah, very excited.
Let's start off just kind of starting with the basics of what is that relationship between weight, obesity, and different rheumatologic conditions and joint pain.
Yeah, no, that's a great question. So this is actually super fascinating because, it's always like this, and you're a physician yourself, so you know all of this, but I think that some patients may not know this. We learn a lot from our patients. And so I actually remember when I was training back in France, where there were patients that would say, when I gain weight, I actually have more pain. And, I didn't think too much of it, but I just kept it like here. And it's really hard to say to someone like you need to lose weight. I mean, because, right, like you can say you need to lose weight, but at the time we didn't have much to offer. And it's like a whole specialty to help patients losing weight. So I kind of refrain myself to tell patients like you need to lose weight, but rather like, how do you feel when you're a little bit heavier versus when you're at your ideal weight? So that would be like the right question to ask. And then studies started like showing that basically there is a pro-inflammatory effect on the adipose tissue, which is like the fat cell. And that pro-inflammatory effect causes flares of rheumatoid arthritis, flares of psoriatic arthritis, which are two very inflammatory arthritis. And we can talk about that if you want. And what's really cool is that you can basically look at the amount of adipose tissue that someone has. And it's almost like you can actually say, okay, those patients have more risk to develop rheumatoid arthritis or psoriatic arthritis, and then they have more chance of developing flares. So by just that itself is a pretty good relationship.
So I didn't realize that. So actually having overweight or obesity can increase your risk of an inflammatory joint disease?
Yeah. Yeah.
Wow.
So in the last 10, 15 years that has shown up, and it's been done. One of my mentor, Dr. Giles at Columbia University, does this work. So he actually like looks at, it takes fat tissue. So there's a couple of ways to look at that, but you can actually look at the fat tissue and then you see that there's some inflammation around it. And so they can correlate with the amount of inflammation there is. In someone, rheumatoid arthritis, for example. But he also like checks and we did that together. Like I helped on one of those papers where you look at the amount of fat that someone has. You can actually like do it's almost like a DEXA scan. You can do a scan and then like calculate the amount of fat there is. In the rheumatology world, it's not so much the weight rather than the adipose content that's pro-inflammatory. Like if your full body mass is muscle, you probably won't have too much issue.
Right.
Yeah.
Yeah. So I think, when I was initially training, and maybe when you were as well, we thought that the relationship between weight and joint pain, say like knee pain, was literally the weight, right? That people were carrying around more weight and that was harder on their knees. And there's a little bit of that, right? I mean, certainly if any one of us were to pick up a 30 or 50-pound backpack, that is putting a little more weight on a lot of our joints. But like you were saying, and like we see with so much of other health issues related to weight, people have sort of a different threshold where there's too much weight for their particular body. And then those adipose cells become sort of, I describe them as leaky. They start just leaking out all this inflammation, which causes problems in lots of different ways, but one of which is in these arthritis conditions as well. So we've really learned that many things, from asthma to GERD, reflux, and as well as joint pain, it's that inflammation coming from the fat tissue that can be adding to a lot of that inflammation. And I'd be interested to hear what you see if you know the data for the conditions that you treat. But for a lot of those conditions, a small amount of weight loss actually leads to a decrease in inflammation because once people start losing weight, their fat cells get healthier and they're not leaking all that. So you don't have to get to a normal weight. Your BMI doesn't have to be normal before you often start seeing the benefit. Is that what you see in the rheumatology world as well?
So yeah, so from my experience, I can talk about my experience, the scientist in me. I don't think we have this data yet because that would mean that we're asking patients to lose weight and following them and seeing how they are doing from a inflammatory perspective. Like does weight loss, I mean, it's probably there, but I haven't seen it. What I've seen personally, and I'm certain that we're starting to look at that. Like, there's no way we're not looking at that. But what I've seen definitely is patients who lose weight and feel a lot better, who have a healthier diet, feel much better, and then who are on those newer drugs to lose weight and like get into remission when we almost got into their like they were almost in remission, but like there was something missing, and then bam, you put them on this, and like they lose a little bit of weight, but like they go into remission. Yeah.
Yeah, so you mentioned some of the newer medications, which I certainly talk about a lot on my podcast, are GLP-1 receptor agonists, things like Wegovy or Zepbound. And, we have started to see them improve a lot of things beyond just weight, right? Like there was just data that came out last week that Zepbound appears to help with sleep apnea, for example, right? Wegovy is reducing the risk of heart attacks for people who are at risk for that, things like that. And I think a lot of us are seeing clinically improvement things in patients that we don't have the data for yet, right? That will take a long time to have enough people see improvement. But yeah, what are you seeing? Because it sounds like you've seen some people who have had improvement in some of their rheumatologic problems from these medications.
Yeah, no, definitely. I see that like very often. So not all of my patients are overweight, but or obese, but the ones that are overweight and obese, they definitely, not all of them for sure, but definitely a significant proportion get much better. And what's really interesting is like, for example, so rheumatoid arthritis, I feel is very easily treatable. Like we have really good treatment, and like I get my patients to remission within like, I mean, honestly, right now, within 4 to 6 months, but within a year, that they will get in remission, like really. Psoriatic arthritis has always been historically, for me, at least from my experience, a little harder to get patients in remission. But psoriatic arthritis, my patients who have that are like a lot of them are actually overweight or obese. And so I remember these patients who had diabetes, and it was at the beginning of the GLP-1 agonist, and no one was using them. And I remember telling her, I think you might benefit from this, even from your psoriatic arthritis. And instead of trying again another treatment when you've tried so many of them, can we try to get you to full remission, like by just losing some weight? And I was expecting that she would come back at 3 months, she would have lost some weight, but we were not there yet, right? Because you don't want to lose too much too fast. But she comes back and she had lost a significant amount of weight. I think she had lost like 20 pounds. 20 pounds is okay. It's not like crazy amount of, especially for her. Like it was good, but it was not like she was still overweight. She was still obese, actually, right? She's in full remission. And so then that got me thinking, and I was like, okay, is there an anti-inflammatory effect of those drugs by themselves, right? And so there was a paper in Nature. It was just a very short paper. I think it was like a 2-page paper where they basically were reviewing some of the data for anti-inflammatory effect of the GLP-1 receptor agonist. And I think the semaglutide. But anyway, so they were finding that the loss of weight, so weight is pro-inflammatory. And I'm sure you say that all of the time, right? So having overweight and being obese is pro-inflammatory. Having too much adipose tissue is pro-inflammatory. That's why I see a lot of patients who are overweight have rheumatoid. Like some people will gain weight and then consequently will develop RA flares, rheumatoid arthritis flares, or psoriatic arthritis flares. But the thing that they are finding is that you cannot explain the anti-inflammatory effect that we're seeing in those patients purely by loss of weight because they are still obese, those patients. Yet they are showing some anti-inflammatory effect on different diseases. And so my paper, like the paper I read was on there was some anti-inflammatory effect in the brain. So they were saying that maybe like Parkinson, it helped for Parkinson, it helped for like a bunch of, different disorder. And so then it's like, wow, I've seen this in my practice. I bet it has an anti-inflammatory effect. And I bet, so basically, right, like one of the main issue in the US is this overweight, is the fact that we are eating very high, like highly processed, very sugary food. And then we create insulin resistance. That's like basically like we have all of those adipose tissue. And as you were mentioning, there is like all of those leakage of inflammation. And basically all of those inflammation is causing all of the harm. And so I follow, of course, rheumatologic conditions, but I also follow breast cancer because that's what I had. And I was like super, like to me, it's been like how I've kept my weight healthy because there is an association of recurrence of breast cancer if you have overweight or if you're obese. And so then I'm like, okay, well, I'm going to try everything to not be there so that I can stay healthy from a breast cancer perspective. So, right, like it's kind of really this exciting moment in medicine right now. I feel like, I don't know for you, but like I always feel that there are those moments in medicine where you're like, I'm so happy to be here. And so I feel like the GLP-1 agonist, receptor agonists are super exciting for you because you use them on a regular basis. And they're super exciting for me as well as a rheumatologist.
Yeah, I
And
mean,
so
that's
I'm
the whole
excited.
reason I've been always excited about helping people with weight for medical reasons, because to me, it seemed really obvious in my training that that was something that was affecting all of the health conditions people had, right? Maybe not all of them, but like 80% of them. And that when we changed diet and we changed nutrition and we changed exercise and we had weight loss, like 80% of things got better, right? It wasn't just about weight. It's never been about weight that I've been interested in this. We see it everywhere. So like I'm not surprised at all that people are feeling better from these meds. But I agree, the last couple years with the growth of these GLP-1 receptor agonists has been like a moment, in history. Like I felt that way when the ACA passed in the US. Like, okay, that was at the beginning of my career, and that was really excited to expand care to so many Americans. And then like this is the next big thing, right? Like now we actually have treatment we can offer people. So yeah, I agree. Very exciting time in medicine. And though as you were talking, some of the things you were mentioning, people have always also talked about with just metformin, which of course is a much easier, cheaper drug to access. And I actually had a patient come to me recently whose rheumatologist had put her on metformin to help with inflammation and thought she might get some additional improvement from her condition from that. Do you know much about metformin for these things as well?
She overweight? This patient is overweight or not even?
Yeah, I mean, she was seeing me. So yes, she must have had overweight or obesity, yeah, as well.
Got it. Well, so that's very interesting. There's a patient of mine that really wanted to be put on metformin, and actually I agreed. I was like, well, what's the risk in free, like if we can try for 3 months and see how you're doing. The data is definitely not as good as the other drugs. I mean, we have unbelievably good
And I
rheumatologic.
think she was on this in addition. Like this, she was not doing this as like her only treatment,
I
but
mean,
it
it
was like
doesn't.
sort of like a little bonus added on top
Yeah.
sort of thing.
I'm not against it at all. I'm actually all for it in the sense of like, right? Like some patients are like, well, I don't really want to be on something. And then you're like, okay, well, what is the issue? And then it's like this additional thing of like, well, I know that I'm overweight. And then you're like, okay, what do you need to help with this overweight? And the metformin is not a bad idea, right? Like metformin probably helps with insulin resistance, and insulin resistance is probably the cause of most of our issues in general. But the data for metformin are just like there is data. There definitely is data. And actually, we read something recently about it, and it was in rheumatoid arthritis. There's some in spondyloarthritis. So that's pretty good, but it's definitely not as
Not as
good as
powerful.
the data.
Yeah.
Yeah, it's I mean, we have incredible drugs. Like that's why I became a rheumatologist. Now in weight loss, you have incredible drugs, but like all the drugs that I use, like all my biologics are so good and so targeted. And I just feel metformin is one of those old drugs. I'm also always like, I've seen like, renal acidity from metformin. And so I'm always like, well, it's not a drug I just feel like biologics are almost like nicer or like Plaquenil, but definitely, why not? Why not? Especially like you try for 3 months and you see how it goes.
If you can see a benefit too, then
That-
then of
yeah,
course makes much more sense whether it's a medicine or a supplement. If you can see the
exactly.
benefit, why wouldn't you want to use
But
that?
I would say, right, like this is such a old drug and we use it all of the time. And the number of patients that I've had on metformin, I've never really seen a significant response to metformin.
Right.
And
Yeah,
so,
and that kind of fits with what we see for weight and other things, right? I kind of describe it as it's like acting in the background, right? It's like it's subtle. It is a more subtle
yeah,
medication often for most things.
yeah, exactly. And I think that's what it is. And I understand where people are like, well, I'm not feeling like trying a biologic or something. I'm like, wow, if it were me, I'll choose the biologic first because it's so much more targeted. So
We'll have
for
to do a
me,
whole podcast with you talking about your amazing
yeah.
meds.
Yeah, my amazing meds. But yeah, anyway, so we have incredible treatments and they are much more targeted. And I don't think metformin is that targeted.
Not adding that much. I want to
Sure.
switch gears a little bit and talk about medications that can cause weight gain, which is something I have not talked about. I might just need to do a whole podcast on the different meds that people could be on that might be affecting their weight. But one in particular that I think of for rheumatology is steroids, or most often prednisone, but other steroids as well, that are well known to cause weight gain for people and often part of the initial course of treatment, at least from what I've seen. So what's been your experience with patients and taking steroids? And is there anything do to decrease that weight gain when people are on them?
So I have a love and hate relationship with steroids. The love is that when you have someone that's in the ICU or in the hospital who has like most severe flare, they are life-saving. There's no question about that, right? So it's not like I'm never going to say we should never use steroids because that's never going to happen. However, in my practice, I try to avoid them at all, not at all costs, but I try to avoid them. One way that I am avoiding them is that I give them intramuscularly instead of orally because it lasts quite a bit of time. And then I feel like the patients don't have dependence on it. So sometimes I get patients who have been on it forever and you're trying to decrease it. But my goal is always to decrease it. So what I'll tell patients, so that sometimes I'll try it as a test. And then I'll tell patients, okay, how you felt on this is literally where we're going. So, right, they'll be like, oh my gosh, this drug was life changing. I finally could function, right? And you're like, okay, well, this is where we're going. We're just going to find the treatment that doesn't have all the side effects. And steroids have so much side effects. And I had only one patient who didn't gain weight on steroids because she developed diabetes. And so she
Oh,
was losing weight from diabetes. She had type 1 diabetes. I didn't put the steroids, but she basically developed type 1 diabetes. And this put her in diabetic ketoacidosis, which is like a pretty severe complication. And so she was losing weight. And I remember thinking, this is odd, like she should not be losing weight. And so then the next day I was like, no, I think you need to go to the emergency right now. And she was in decay, almost went to the ICU. And the doctors were like, how did you figure it out? I'm like, she was losing weight, peeing, and being always thirsty on the steroid, on 20 or 30 milligram of prednisone. I mean, there's no way. Usually you gain weight.
Yeah, wow.
So yeah, that was like, that's good, right? Like when you see that and you're like, okay, well, I can, we can help the patient pretty fast just based on that. You should not be losing weight if you're on prednisone. If you are, then there's something off.
Yeah. So that
Um,
really hammers home like how much weight gain people do have on it. So I think sometimes people get dismissed a little bit when they feel like they've gained weight as a side effect of a med. And it's absolutely true, right? It's often really outside of someone's control when they're on prednisone or another
oh,
steroid with that
totally.
weight
Like,
gain.
prednisone is awful. Like, I mean, in terms, again, it's amazing and it's awful, right? But yeah, absolutely, you're right. Like, I don't think I know anyone that doesn't gain some weight. And if they don't, it's usually that if they just are stable and are just like gaining 1 or 2 pounds, it's usually that they have so much activity from their arthritis or like their inflammatory
Mm,
process that basically they have all of those cytokines, like including the TNF, and TNF causes weight loss. And I think it's just that you haven't been able to, like balance that like release of this pro-inflammatory marker, like and cytokine. So this protein that causes weight loss.
I had
Yeah.
one patient who was on chronic steroids for lung disease. Actually, she's young, and the first few times she did long courses, she didn't gain any weight. And then as she got older and had to go on them again, she really struggled. And so I actually, every time she goes on a course of steroids, now we use phentermine short term for her to decrease that weight gain side effect instead of waiting for, her weight to really go up. We just we know that while she is on prednisone for often months at a time that she, needs an appetite suppressant to be able to mitigate that. So that's one thing I've done in my practice when I've seen someone who, I'm like, why wait? We know where this is going, right? Like,
Yeah.
why wait for this to become a bigger problem?
Yeah.
So, one of the things when I've seen you speak and some of what you've written is kind of talking about this relationship between stress and inflammation. So, generally speaking, can you tell us a little bit about stress and its effect on the body?
I love this question. And I think I'm going to share my own story. So at a little over 40s, that was 5 years, a little bit more than 5 years ago, yay. I got diagnosed with stage 4 breast cancer, and scary, very. And what happened is that I was looking at what can I do, what's in my power to do, and I was really like interested in the power of placebo. So it's actually very interesting. Like being a rheumatologist allows me to be extremely optimistic because I see patients in remission all of the time, right? And I've seen like really what you could call medical miracle patients who are in the ICU, hemiplegic, so half of their body wasn't working, in the coma, and being totally normal later on. I've seen patients in the ICU intubated with lung nodules everywhere, like severely affected, and they're perfect and they have babies and they have a normal life. And so I've always wondered, like, what makes those patients do better than some other ones, right? And so then I went really deep into, I did a journey, like it's really a journey. Like when I, like in the bio, it's really that. It's like understanding what, so yes, of course, there's Western medicine, but then what is the power of placebo? And because I'm a scientist, I kind of put it all. I don't know that like placebo is basically you're giving sugar to someone and it's gonna work. Like there's 30% chance that they're gonna be better, right? But what is that, and how can we get it without having your doctor giving you a placebo, right? That's unethical. And what I found is that if you work on healing your body and allowing your body to heal, you decrease stress level. And so basically, stress is pro-inflammatory. Cancer or rheumatologic disorder is due to due and causes inflammation, right? So we know that a lot of cancer are basically due to to chronic inflammation in our body. And so then you're like, okay, well, what is stress, or what is the opposite of stress? So stress is basically this adrenergic system that's being, I don't want to go into like scientific term, but it's actually very easy, right? We were born like a long, long time ago, and there were bears and there were wolves, and we had to fight those, and we had to either fight or flee. And so basically, when you have that, then you have to breathe very high. You have to have a heart rate that goes fast. The blood needs to go to your muscle so that you know, like that you're able to fly and run, or you're able to fight. Of course, at those times, when you're doing that, there is no point of your blood supply or all, whatever of your body going to the healing part of your body. You're not going to heal when you're fighting a bear. It's just not going to happen, right? But the thing is that you need that balance. And so you need the parasympathetic system, which is like the opposite of the adrenergic system. And so you need to calm down. You need your blood pressure to lower. You need your heart rate to lower. You need like breathing to increase and expand. You need to sleep. You need to heal, right? You need your immune system to heal. And that you're going to get in the opposite of the stress in the parasympathetic system. And how do you tap into that parasympathetic system? To me, that's what some of the placebo does. It's like you go and see a healer, and they look at you and they're like, you are going to fine. You're going to do fine. I see those people. Because they make me feel good, and I do not care if there's science behind it or not. I do care, actually, that's not true, but let's put it that way. It makes me feel good, and that's what's important. And I know that maybe that is placebo. I don't think it's placebo. I think what they do is that they activate my parasympathetic system. They allow me to take a deep breath and just say, okay, well, I've got this. Like, I'm going to allow my body to rest. And instead of being in this fear mode of, will I die from this cancer, or will my rheumatoid arthritis destroy my joint, I'm going to stop and I'm going to sit and I'm going to look at it. Because I mean, if you want to just compartmentalize it, it's going to run in the back of your mind. So it's going to stress you out. So you look at it, and then you're like, okay, well, I understand. I acknowledge the fact that I'm stressed out about it, but now I want to allow my body to heal. And so while I'm acknowledging that, I'm also going to try, and it doesn't work all of the time, right? But I'm going to try to look at healing, to look at where I'm doing well. And so that's the workout visualization. And I love, love, love doing that. So I do PET scan every 6 months, and I can tell you, like, I'll have another one at the end of the month, at the end of May. And I will draw like how I want to feel when there's this PET scan. Look, at the end of the day, I'm not responsible. I cannot, whatever happens, right? But I can heal. I can try to heal so that I'm not constantly in the stress of the fear of recurrence or the fear of something happening. And so then, like, just working on getting more grounded so that I can heal, so that I can allow my body to heal. And so that's like really something that I'm looking into right now. Like, I'm really thinking about this. I mean, I'm still a researcher, but I was really a researcher when I was at National Jewish and Columbia University. I've done research for like 15 years. I love it. But there is something about the naturopathic way, the Ayurvedic way, the whatever, like, you can call it like shamanism. There is something that's really empowering to our patients. And I think that instead of saying, oh, this is BS, we can actually say, no, actually, like, what is it that they do so that I can bring it to my patients as well? Sorry, I can talk about this for
I
hours.
love it.
So
No, I
passionate.
mean, there were so many things there. I'm trying to, I think, some of what you've described is that feeling of letting go of control.
Yeah.
And when you pair that with feeling like something has your back, whether it's that placebo you're taking, a healthcare provider that you have turned your health over to and that you have faith in, whether it's maybe just faith, right? For some people, and why we see the power of prayer. I mean, they've done studies where people like heal better when people are praying for them, right? Like, science doesn't explain that very well, but the data was there, right? So I think that there is a lot of power to that, and we know stress has tremendous impacts on health and weight.
Yeah.
On the weight side, there's this whole movement of people called health at every size, and some of the things they do is very good, and some of them are a little more controversial. But one of the points they will argue is that all of the health problems that are related to having overweight or obesity is because of all sort of the stress and stigma and additional stress and social determinants of health that go along with having obesity. And while I don't think that that's entirely true, because I also know the science of insulin resistance and inflammation and all of that, I do think that there is part of that, right?
Yeah.
That it is a very stressful way for a lot of people to live, and it just self perpetuates, right? And so and anything when I'm sure you see this a lot with chronic illness. Once someone is sick, it can often be very, very scary and anxiety provoking. They no longer trust their body. They're kind of waiting for the next bad thing to happen. And those are the people whose health often continues to deteriorate, and they end up on more and more medications. And so I think what you shared is incredibly powerful to recognize there is science behind why stress impacts our health, and that there is something we can do about it.
Absolutely. Yeah. Yeah, absolutely. And I think to me, it's empowering patients. How do we make sure that the power is back to the patient? Because I think that there's a lot of ego in the world of Western medicine. And we like physicians tend to not have a lot of time. I love the direct care model for that because I think we listen a lot more to our patients, right? It's not, I think, I'm sure. That's the reason we're doing that. But, if you go in an insurance-based model, like you're one after the other, even me as a patient, I'm seeing that and it's painful. And if the patient starts to say, well, no, I don't want to do that, you're not listening to them, and you're like, well, how come you're not listening to me? I'm the doctor, right? Like I've seen that. And you're like, well, I mean, who is important here? It's not the doctor, it's the patient. And how do we empower them? How do I explain to the patient, okay, what can I do to help you go into remission? What can I do to help you go into your healthy weight, whatever that is, right? And it's funny because I have struggled. I want to say it in the past. I have struggled with weight. I've always been like on the higher side of the BMI. I would be 25, 25.2. And I told you, right, there are those studies that show that more than 25 a BMI, you have more risk of breast cancer recurrence. And every time that I'm like, well, I need to lose weight, I need to lose weight, like it doesn't help me. And it's just like, how do I get back my power of like I can choose whatever I want, like this is okay, like I'm gonna have a healthy relationship with my food. And I will just share the story because it's kind of funny in terms of empowerment. I got access to semaglutide, and so I had one of my colleague friend gave me semaglutide, which is like same, right, like one of those new drugs. So I looked at it and I had it in front of me, and I was about to get it to myself, right? Like I'm looking at it and I'm like, okay, well, I don't want to be at this BMI because it's stressing me out. And then I remember I was like, okay, have I done everything that I can do to lose weight? And I looked at the semaglutide and I said, no, I have not. Let me try first. And so I started just eating healthier without frustration, nothing, exercising more. And I've lost 10 pounds. And I still have the semaglutide in front of me, like just kind
Or
of
like
like,
it's still having that placebo effect for you.
isn't
You
it
know it's there.
insane? It's
You know
there.
it's
And
there. You know you
so
have an
funny.
option maybe.
Yeah, it's so funny. But again, what did that do? It's literally empowering me to say, if you want to try this, you have the ability to take that. I'm giving you that power instead of saying, no, you're not a candidate for this. Like, this is not, you're not part of the study. And I was like, well, but my BMI is over 25 and it's stressing me out. And then suddenly it's like, well, I have the semaglutide, I haven't taken it, but I'm looking at it and I'm losing weight, And the reason I'm losing weight is just that I'm healthier, like in my choice, and I don't eat. If I'm not hungry, I don't eat. And, things like there's many reasons, but it's cool. To me, that was like, it's cool. It's really cool to see that, right? The power, it's not placebo. I don't even know. It's the power I don't know, like visualization, I guess. I don't even know how you would call it, and it doesn't really matter. But I told this to one of my patients. I was like, look, I can order one, or you don't even have to order it. Just know that I will order it for you if you need to. And then just think of it and, do what you have to do and do what you want to do.
Well, Dr. Amigue, I feel like we could probably talk all day. Any final thoughts that we didn't cover, or is there a way people can connect with you or learn more about what you do?
Yeah, well, thank you. First of all, I've really enjoyed this conversation. I think I can talk forever about rheumatologic disorder, like stress and weight, honestly. Like it's not weight, actually, really, like it's adipose tissue. But yeah, no, I think that was great. Otherwise, we would have another 2 hours. And well, you can find me at Unabridged MD. So the name comes from the fact that I wanted to see patients in their whole. So non-edited version of the patient and non-edited version of me, so that you get the full of me. And so it's unabridgedmd.com. You can look on our website, and we are in Denver, Colorado. I see patients in person and on telehealth. And otherwise, you can follow us on social media at unabridgedmd. And I also have a YouTube video channel that's called Rheumatology 101. I think it's Rheumatology 101 by Dr. Amigues. But honestly, if you just put Rheumatology 101 and my name, you find it. And it's kind of fun because I do lives and we talk about rheumatologic stuff, which is, 10, 15 minutes, and it's always fun. But yeah, that's me.
Awesome. Well, thank you so much. And until next week, take care. Thank you for listening to the Dr. Francavilla Show, where we learn about all things related to weight and health. If you love this podcast, make sure to leave those 5-star reviews and share this podcast with a friend or loved one. If you have a topic about weight and health you want me to tackle, head over to the website, thedrfrancavillashow.com, to submit your question. And make sure to subscribe to the podcast so you don't miss next week's episode. Take care.